Okay, hello and welcome to the 13th lecture in the immunology course. In this lecture, I'll be talking to you about the immune conditions that might affect the nervous system, the central and peripheral nervous system. I will start with several questions, and hopefully by the end of this lecture, or at least by the end of the first part, we will be able to answer these questions. The first question is, does immune reaction take place in the nervous system? And if it does, this means immune cells are present in the nervous system. And how does this fit with the fact that the immune system is the central nervous system is one of the immune privileged sites? The second question is, are the immune cells in the nervous system similar to those in the periphery, like normal macrophages, T lymphocytes, antigen presenting cells, or is there unique and specific type of inflammatory cells in the nervous system? So I'll be presenting to you different types of cells that are present in the nervous system. And the last question is, are the peripheral immune cells allowed to cross the blood-brain barrier, or is there sort of privacy or privilege that is given to the central nervous system that would prevent these immune cells to cross over and get to the central nervous system? So all of these questions, hopefully, we will be able to address during this lecture. So this figure shows the nervous system, the central nervous system presented with the brain and the brainstem, and here the spinal cord. And also we can see the different nerves that come out of the spinal cord, the somatic nerves, whether they are motor or sensory, and the autonomic nerves, parasympathetic and sympathetic nerves. So, as I stated before, the central nervous system, including the brain and the spinal cord, are considered one of the privileged sites where the immune cells are not allowed to access or, just freely move within these structures. Very much similar to the eye structure, where it has its privacy, its specificity that would not allow the immune system. They are so delicate structures, they cannot tolerate a massive inflammatory reaction in response to any pathogen or antigen. So going to the first question, do immune reaction takes place in the nervous system? And the answer is yes. There are different immune responses and reactions that can take place in the nervous system, and we call that neuroinflammation. So neuroinflammation can take place in the brain or in the spinal cord, either as a primary response to infection, like for example viral encephalitis, like meningitis, for example streptococcal meningitis, which is a bacterial infection that affects the meninges in the brain inside the skull. And it also can be a secondary to a systemic process, like for example SLE. So one of the complications of the systemic lupus erythematosus is the formation of immune complexes that manage to get access to the brain and precipitate there, inducing neurological deficits and neurological features of the systemic lupus erythematosus. So the question is yes, inflammation can take place, immune reactions can occur within the central nervous system. The question is, what type of immune cells that conduct that inflammatory reaction? So to answer this question, we need to go back and broaden our knowledge, or revise what we know about the type of cells that are located within the central nervous system. The central nervous system consists mainly of two cells, the neurons that conduct the function of the brain or the function of the of the spinal cord, and the glial cells or neuroglia. So any cells that are responsible for conducting the signals, they are neurons. Any cells that do anything else are neuroglia or glial cells. The glial cells, we have billions of neurons within the central nervous system, but we have 10 times more of glial cells, because they are the ones that nourish, the ones that support, the ones that maintain the integrity and the health of the neuronal cells. So different types of glial cells and different names to ones that are located either in the central nervous system or peripheral nervous system. So the first one is astrocyte, and we have satellite cells that are the ones located in the peripheral nervous system. We have oligodendrocytes, and Schwann cells is the parallel one in the peripheral nervous system. We have microglia and ependymal cells that are located in the central nervous system. Let's have a look in details about these cells. So these are the neurons. They are covered with the myelin sheath, and this is the oligodendrocytes. These are the microglia, and this is the astrocytes. And let's start talking about the astrocytes and satellite cells. The name astrocytes means star-like, and this is because it looks like a star. So it is based on its shape, and it is the most abundant type of neuroglia. It actually does all the job in the brain, all the hard work, the housekeeping, the homeostasis, the repair, everything. It does everything in the brain. So it controls the chemical environment. The electric or the signals depends on the potassium concentration, sodium concentration. So it works on maintaining the electrolyte balance within the central nervous system. It also provides the neurons with energy. Neurons requires a huge amount of glucose to conduct its function, and of course it cannot store it and it cannot synthesize it. So it relies on the brain to provide these neuronal cells with the glucose that comes through the blood vessels in the brain. These astrocytes have the capability to store glucose in the form of glycogen, and when needed, it converted into lactate, and this lactate can be used as a replacement for glucose when there is a shortage of glucose. So it maintains these neuronal cells with energy so that they can conduct their function. Also, they are responsible for clearing the synapse. For a healthy neuronal communication, the synapse should be cleared continuously after signaling. So when the synapse is cleared, and this is usually done by the reuptake of substances, or maybe by washing out, or maybe by enzymes. So the synapse should always be clear after conducting the signal. So the astrocyte does that function by clearing out the synapse, removing any remnants of chemical or or mineral electrolyte substances within the synapse. The astrocyte that forms the most abundant form of cells, it forms a meshwork that holds everything together, hold all the cells, the structures, the blood vessels, hold it all together. And if there is any injury or any problem within the central nervous system, it tries to localize that deficit by forming a scar. And this scar would, sort of localize, form a borders or a fence around that lesion, and preventing it from interrupting the adjacent neurons and adjacent neuronal activity. And we call that glial scar, or astrocytosis, or gliosis. So all means the localization of the site of injury. Another function which is currently under debate is the support of blood-brain barrier. So as you can see here, the astrocyte, it has that foot-like projections at the end of these star-shaped endings, and these foot-like projections, they hold the endothelial cells of the blood vessels. So one of the suggested functions of astrocyte was their ability to maintain the integrity and the tightness of the blood-brain barrier. New research now is questioning this ability, and so it is now under debate whether it is responsible for maintaining and optimizing the function of the endothelial cells to act as a blood-brain barrier. However, it does, attach or adhere to the endothelial cells within the blood-brain barrier. Whether it is important for its function or important for the endothelial functions to maintain, to act as a barrier, this is not actually confirmed. This shows you the satellite cells that are located in the peripheral nervous system. They look slightly different, but still they have the star shape, and they conduct exactly the same function of the astrocyte. So different names refer to different sites, but similar functions. This image shows us what happens during central nervous system injury, and it mainly looks at the function of the astrocyte. So these in sort of a bluish green color cells, these are the astrocyte, and these are responsible for holding, or let's say making a fence surrounding the site of the injury, and to localize it, prevent any interruption of the neuronal cells. Very similar thing happens where fibroblasts do localize or try to localize the site of injury in the peripheral tissues. You can see the bacteria here, the inflammatory cells. Well, in the central nervous system, pathogens are not allowed in, so it's usually sort of a sterile inflammatory reaction where there is no pathogens at the area. Okay, and this image here shows us the how the injury, how the gliosis or astrogliosis happens in the brain. When it is surrounded with this fibrous tissue, it would appear in the MRI as sclerotic area. The second type of cells is the oligodendrocytes and Schwann cells. Both conduct the same function, which is synthesis of myelin sheath. But there are differences. So oligodendrocyte is the cells that are located in the central nervous system, responsible for myelinating the nerves within the central nervous system. However, Schwann cells, they are located in the peripheral nervous system. You can see here that the oligodendrocyte, which is one single cell, would be responsible for providing myelin sheath for different sites and different neurons. While the Schwann cells, each wrap here form one single cell. So here we can see three cells covering, or three Schwann cells wrapping the axon of the peripheral nerve, while here it's one single oligodendrocyte that wraps different neurons at different locations within the axon. So this is the difference between Schwann cell and oligodendrocyte. The microglial cells is a specialized type of macrophages. So remembered when we talked about the different types of inflammatory cells, and we stated that there are different specialized form of macrophages, like for example Kupffer cells in the liver, microglial cells in the brain, and other different cells at different sites in the body. So microglia or microglial cells, these are macrophages that has been transformed or changed to fit in the new environment. So this is how microglia looks like. With again, it's similar to star shaped or like ice chip, and when this is how it looks like when it is in a dormant stage, but when it is activated, these processes are decreased in size and the cell got bigger until when it is completely activated it looks exactly similar to peripheral macrophage. It does all the functions that a macrophage can do. So it can phagocytose an antigen, it can produce products like reactive oxygen species that is able to digest and destruct a pathogen if it is present, and then it can phagocytose that pathogen. It can degrade it further, and it can present it on MHC molecule on its surface. So it can present it to different immune cells that might be present at the area. And in fact, there are lymphocytes that can be present in the white matter of the brain. These lymphocytes, of course, they would never be as abundant as they are in the peripheral tissues, but there are certain areas within the brain where the blood-brain barrier is not as tight or as regulated as in different parts of the brain. So certain areas would have more loose junctions in the blood-brain barrier that would allow the T cells to get in there. Also, any inflammation, any neuroinflammation that starts either due to infarction, bleeding, trauma in the brain, any beginning of the immune reaction within the brain might induce inflammatory cytokines that would also loosen that tightness in the blood-brain barrier and allow the inflammatory cells to get into the brain. Also, these macrophages have the ability to produce cytokines like interleukin-1, interleukin-6, and TNF, which will recruit further inflammatory cells and induce changes within the environment of the central nervous system. So, inflammatory cells do occur in the central nervous system. There are specialized forms of inflammatory cells, including the microglia, and it is able to conduct the inflammatory reaction. It can initiate it and it can maintain it. Also, there are T cells and B cells that can arrive from the periphery to the central nervous system, not as much as they accumulate in the peripheral body part of the body, but they can still aggregate at a lower concentration or lower amount at site of inflammation in the brain. And the last type of cells is ependymal cells, and these cells, they are located between the compartments of the ventricles, and between the ventricles and between the brain tissue, the parenchymal tissue of the brain, and it is responsible for synthesizing the cerebrospinal fluid. So this is a cross section of the brain here, and you can see the gray matter usually, or it is always located at the outer part of the brain, and inside we have the white matter. These are the ventricles of the brain where the CSF fluid goes through and bathe the surface structure of the brain, and also can go through the sulci and clefts in the brain. On the other hand, this is a cross section of the spinal cord, and it is arranged opposite to the brain. So you can see the white matter is present on the periphery and the gray matter is present in the center, and we have here the central canal where the cerebrospinal fluid pass through. So the cerebrospinal fluid, it's a continuous compartment of the ventricles going through the central canal um, in the spinal cord. So if we concentrated at these ventricular areas and these spaces where the cerebrospinal fluid go through, and if we magnify it, so this is how it looks like. So this is a cross section or a magnification of this area at the border of the ventricles in the brain. And here you can see the ventricle. Here is the cerebrospinal fluid, and here is the parenchyma of the brain. You can see the neurons, the astrocytes, the microglial cells, and the oligodendrocytes having these these myelin sheath surrounding different parts of the neurons. So here is our ependymal cells. So they are located in the junction between the ventricle and the brain. They are responsible for synthesizing cerebrospinal fluid that goes here in the ventricles. Also, it conducts the transportation. So any metabolic waste or products are sent to the ventricles, the cerebrospinal fluid. Any nutrients, any substances that comes through the ventricles, they can reach to the parenchyma of the brain through these ependymal cells. So to summarize what we have just discussed now, we have different types of glial cells or neuroglia. These are the neuroglia. Those are the ones present in the central nervous system, and here the ones in the peripheral nervous system. We have astrocytes. Stellate is their counterpart in the peripheral nervous system, and they do all the homeostasis, all the housekeeping work of the central nervous system or peripheral nervous system. Oligodendrocytes and Schwann cells responsible for myelination. Microglia are the macrophages of the central nervous system responsible for the immune responses, initiating and propagation, and also they can produce cytokines and can do phagocytosis. Ependymal cells, they are responsible for synthesizing the cerebrospinal fluids. So till this minute we have answered two questions regarding the presence of the inflammatory reactions and presence of immune cells within the nervous system. The last part is the blood-brain barrier, and here you can see this is a blood vessel within the brain, and these are the endothelial cells that act as a barrier that prevent any communication between the brain and the blood that gets through. These are the astrocytes with the foot-like projections surrounding and maybe supporting the endothelial cells to act as a barrier. These are, I think these are neurons, and this is the myelin sheath here. Okay, and remember in the inflammatory reaction in the periphery, these white blood cells, the lymphocytes or neutrophils, can sense and feel the presence of chemokines and cytokines which are produced somewhere here in the tissues. These signals can get through the endothelial cells, can stimulate and activate these neutrophils to migrate from the central stream of the blood to come to the periphery with the process of margination and then migration to the periphery. This is how things, as easy as that, things used to happen in the peripheral tissues. In the brain, things are not that easy, not that simple. The white blood cells are not allowed to get through these endothelial cells because these endothelial cells are so tightly bound to each other. So it's not just an endothelial cells contacting each other that would allow the pinocytosis or the squeezing of the white blood cells between the two cells to get through. There are actually gates between these cells. And these gates would allow certain molecules like water or gaseous molecules to get through. They can allow lipophilic substances to get through the cell itself. So lipophilic medications, they can easily cross the blood-brain barrier and get to the brain. Specialized molecules that are needed for the health and nutrition of the neurons are also able to get to the brain through specialized receptors. But other molecules or other cells are not allowed in. The only way a cell can get through, a T cell or macrophage or neutrophils or antibodies, for example, they can get from the blood to the brain is when there is a breach or a leak in the blood-brain barrier. This is the first possibility. So when there is a beginning of neuroinflammation within the brain, this might induce or produce certain cytokines by the microglia, and this would induce certain changes and increase the permeability of the blood-brain barrier, allowing more inflammatory cells to come in within or to come in to the brain. Another scenario is that the blood-brain barrier, although there is tight junctions between the endothelial cells, but this is not fixed at all sites of the blood vessels and not at all sites of the brain. There are certain sites, particular areas of the brain where the blood-brain barrier is not as strict as in other sites. So the inflammatory cells might manage a way or find a way to get to the brain. But when there is when there is a severe inflammatory action within the brain, when there is, like, for example, infection, the blood-brain barrier would be breached and would be damaged, allowing the influx of inflammatory cells. So this is the end of the first part of the lecture, and where I tried to answer certain questions about the presence of inflammatory cells, the process of neuroinflammation, and different types of cells that are present in the nervous system. This would allow us to discuss the different conditions where things goes wrong related to abnormality or dysregulation of the immune system. And the first example is the multiple sclerosis, where the problem is restricted to the central nervous system. So multiple sclerosis is a chronic, progressive, degenerative disorder of the central nervous system. So it affects the brain, the spinal cord, and the optic nerve. And the exact nature of the condition, whether it is an immune-mediated or autoimmune, is not really known yet. It's not confirmed. There are several piece of evidence and research that support the hypothesis that it is an autoimmune condition, but it is not really, or it's not yet confirmed. So we know it is immune mediated, we know that there's dysregulation, it might be an autoimmune, but this is not confirmed yet. It is most common in the Northern European ancestry, and more common in the temperate area. So we'll find higher prevalence of the condition as we get closer to the poles, to the North Pole and Southern Pole, and as we get further from the equator. So this indicates sort of environmental factor. This might affect the different types of pathogens that are located on at this temperate area, or maybe the temperature itself, the amount of sun exposure itself is contributing to the condition. Multiple sclerosis is usually diagnosed between 20 and 50 years old. This is a big range. The median is around 25 and 30 years of age. Usually women are more affected than men, which is similar to the autoimmune diseases trend. The cause of it is not really known yet. We know there's a genetic predisposition. We know there are people who are genetically susceptible to develop the disease. HLA-DR15 was associated with the disease, and there's a 25% concordance rates in monozygotic twins, which indicates the presence of a genetic factor. And there's increased risk in relatives. Maybe these relatives might not produce the full-blown multiple sclerosis condition, but they would have, for example, high antibody titer. So there is a genetic clustering, or there is a familial clustering of the condition. So this indicates the presence of a genetic factor. Environmental triggers are needed to initiate the condition, and several environmental conditions were associated with multiple sclerosis, including decrease in vitamin D, and this contributes to the immunity. Presence of infectious agents, several viruses, very common viruses like measles, rubella, and mumps. So these infectious agents were reported to be associated with multiple sclerosis. Actually, a flare-up of multiple sclerosis were seen after vaccinations, which suggests the role of infectious agents. Could be through mimicry, maybe. So it has a role in inducing the condition. The temperature, as I stated, and the socioeconomic status of the individual. So some related it to high socioeconomic environments where these people tend to get exposed to different pathogens at older age. That would trigger the multiple sclerosis, and some related it to lower socioeconomic status where the people would or a person would be at poorer general health and make him more susceptible to develop multiple sclerosis. So this is sort of a active area of research. So different genetic susceptibility, environmental triggers would induce autoimmunity or immune dysregulation that will lead to loss of myelin sheath in the fibers. If we want to discuss in details the immunological background or abnormality that happens in multiple sclerosis, it is mainly related to CD4 T helper cells. They are the key players that initiate the immune and the inflammatory reaction. So what happens here? We have, so the problem is the myelin sheath is being recognized as a foreign antigen. T cells would consider this myelin sheath as foreign, and this could happen in two ways. Either from the inside the brain, so this is a microglia, which is the central nervous system macrophage. The microglia is responsible for clearing up the debris and any damage in the brain. So among the proteins that it might pick up is the damaged myelin sheath. So it will process it and it will present it on its surface. It is very possible that this antigen is presented to a T cell. Definitely there's a sort of immune regulation that this T cell was able to recognize this self-antigen and react to it and initiate an inflammatory reaction. So the whole process might be within the central nervous system. Another let's say suggested mechanism is that the antigen presenting cells from the periphery was expressing an antigen maybe it's a foreign antigen, but it is very similar to the structure of the myelin sheath or part of the myelin sheath. Remember that the antigen presenting cells would not present the whole antigen, it would present an epitope. So it is presenting this epitope, and the T cell from the periphery reacted to this epitope, and because of certain breach in the blood-brain barrier, and also there are certain sites in the brain, within the brain, where the blood-brain barrier is not as tight as in the rest of the brain, so the T cell managed to get into the brain and initiate an inflammatory reaction against myelin sheath. So this is how we can get an activated T cell, an activated helper T cell that would initiate an inflammatory reaction. So this activated T cell, helper T cell, it will produce different types of cytokines, including interferon gamma, for example, and this would stimulate the macrophages. Macrophages in turn would also produce different types of cytokines and will start attacking the myelin sheath. Also, the T helper cell is responsible for stimulating the CD8 cells, the cytotoxic T cell, that in turn would also attack and damage the oligodendrocytes, for example, or the myelin sheath. Also, the helper T cell would stimulate the B cells, turning it into plasma cells that would produce antibodies that recognizes the myelin sheath and bind to it and opsonize it for destruction. Here it shows communication between the helper T cell and the astrocytes. So the astrocyte would also get activated and would be, trying to. It will recognize the presence of the damage of the myelin sheath, and it will start repairing the myelin sheath. So there is a continuous process of destruction. Either it's all initiated by helper T cell, conducted by macrophages, cytotoxic, or B cells that would induce the destruction of the myelin sheath. The astrocyte is trying to repair and maintain the myelin sheath on the other hand. So this is why we have sort of a damage followed by a repair, and this is why we have in multiple sclerosis the symptoms are not continuous. The patient goes through periods of remission when there is repair and flare-ups when there is damage or excessive damage of the myelin sheath. So in this image, it shows us the different patterns of multiple sclerosis, how multiple sclerosis is clinically presented. So some patient, this is the most common form of multiple sclerosis presentation, which is relapsing remitting multiple sclerosis. So the patient will be normal, and all of a sudden he would have a flare-up with severe symptoms of weakness, numbness, so either motor or sensory, symptoms that I will present to you later. So the patient would have this flare-up, then things will calm down and he will be in a good shape for certain period of time, maybe months, until he have the second relapse or the second flare-up. And so here where the repair takes place, where the astrocytes are doing their job in maintaining the health of the myelin sheath, and here where the inflammatory reaction is exaggerated and there is a big damage in the sheaths. So the patient will keep going through periods of remission and relapse, remission and relapse. And notice between the remissions there is no progression in the disease. The disease is in a stable condition. So this is a relapsing remitting multiple sclerosis. Of course, with time there is a cumulative sort of a damage to the nerves, and this is why things tend to get worse. So this is here the increase in the disability. With time, there is an increase, generalized increase in disability. This is the most common form of multiple sclerosis. There is other form, which is primary progressive. And in this condition, the patient is actually, once diagnosed with multiple sclerosis, he will keep progressing in the disease. There is no areas or no times of remission, and just going, progressing with deterioration. The third type is the secondary progressive multiple sclerosis. So the patients start with relapsing remitting, similar to this one. So having flare-ups and remission, stable during the remission stage, and then flare-ups. But at the end of the condition, the patients start to deteriorate progressively. There is no relapse and remission. The last form is progressive relapsing. So the patient is actually progressing along the time, but he had periods of relapse. And note that during the relapse period, there is no stability. There is also progressive increase in the severity of the symptoms. So these are the clinical patterns of multiple sclerosis. Multiple sclerosis, has a broad range of severity, from just mild condition with mild symptoms with few relapses and slowly progressing condition into a really disabling disease. Now let's talk about the clinical manifestations. What are the symptoms that the patient would complain from during the episodes of relapse? There are motor manifestations, which include weakness or paralysis, diplopia due to the paralysis of the ocular muscles. The speech would be affected, the spasticity of the muscles, so the patient might complain of stiffness in the muscles. So these are motor manifestations. There are also sensory manifestations. The most common one is numbness and tingling sensation. Neuropathic pain, different types of neuropathic pain, either chronic continuous neuropathic pain or episodic pain. Also, the optic nerve would be affected. The patient would have blurred vision, vertigo, and tinnitus. So all of these indicating the cranial nerves being affected with the process of demyelination. Cerebellar manifestations including nystagmus, ataxia, dysarthria. The patient cannot coordinate speech, or dysphagia, also difficulty in swallowing. Emotional manifestations including depression, anger, euphoria, and all of these, it follows which areas in the brain were affected by the gliosis or sclerosis, where damage or demyelination happens in the brain. So the inflammatory action will induce demyelination. Of course, the demyelination would start by damaging just the myelin sheath, and then the myelin sheath would be repaired by the astrocytes, as we saw. Later, with the continuous progression of the disease, the myelin sheath would be affected, and the cytotoxic T cells would also affect the neurons. So there is a damage, irreversible damage of the neurons. And these areas would be surrounded by the astrocytes that would try to localize this damage by gliosis or sclerosis. So the symptoms, it follows which area in the brain were affected. Other clinical manifestations like sexual dysfunction, like bowel and bladder dysfunction, incontinence. So all of these are different clinical manifestations. To diagnose the condition, we rely mainly on the clinical manifestations, taking the history from the patient, ruling out other causes of the symptoms like Lyme disease, for example, and doing the MRI, which demonstrate the presence of plaques of the hypersclerotic area. Antibodies are present at high levels in the cerebrospinal fluids that can be measured also to confirm the diagnosis. These images are for the MRI showing the hypersclerotic area in the brain. And here the patient is having also hypersclerotic area in the spinal cord. Treatment, actually it's a symptomatic treatment, so it depends how bad it is affecting the patient's life, what are the types of symptoms that the patient complain from. Usually patients complain from motor involvement, like stiffness, they are treated with baclofen. And pain also is another major symptoms of multiple sclerosis, different types of neuropathic pain. So they are treated accordingly with medications like gabapentins, SSRI also. So in treating patients with multiple sclerosis, it depends on the symptoms. So to manage the symptoms, so medication differs based on what symptoms the patient have. Steroids can be prescribed for acute exacerbation just to reduce the amount of inflammation. Interferon beta was found to be beneficial and it affects the progression of the disease. A new medication, which is still in the phase 3 studies, include Copaxone. And this medication consists of an epitope or sequence of amino acids similar to the epitope that initiates the inflammatory action in multiple sclerosis. So hopefully by having this medication, it will target the T cells that are activated with these epitopes, and it will also block the antigen presenting cells that are presenting that particular epitope. So it will not affect the inflammatory reactions in general, it will just target the cells dealing with that specific epitope that was found to be associated with multiple sclerosis. So this is one example of a condition that affects the central nervous system, where the immune reaction attack part of the nervous system, which is the myelin sheath. The second example is the myasthenia gravis. This is an autoimmune disease that affects the peripheral nervous system. In myasthenia gravis, the patient complains of muscle weakness, and this muscle weakness is noticed upon repeated use of the muscle. So the patient will wake up, normal, no complaint, no fatigue. But as the day goes on, the patient would feel weaker, and the worst time of the patient is during the evening, where the muscles are really tired and fatigued. Also, the patient would feel fatigue with any sort of repetitive movement. The muscle cannot keep, going and cannot keep working. It will, go into a fatigue state quickly. The condition affects all types of striated muscles. So all striated muscles are mainly are affected with the condition, mainly the ones that are innervated by the cranial nerves. So the patient would have, the oculomotor is affected. So this would affect the eye, the muscles supporting the eyes, and the patient would have ptosis. All the muscles, the masticator muscles are affected, neck muscles are affected because they are supplied by the cranial nerves. There are circulating antibodies to acetylcholine receptors in 85 to 90% of the patients, while in 10 to 15% of patients, they do not have these circulating antibodies against the acetylcholine, and they will have it against a muscle-specific kinase or MuSK protein. So let's see what goes wrong in myasthenia gravis. The problem with myasthenia gravis is the presence of these antibodies, and the antibody here, the IgG you see here, is attacking the acetylcholine receptor. So normally when there is at the neuromuscular junction, the nerve will produce acetylcholine, and the acetylcholine would bind with the receptor and induce the function of contraction. Now, when these acetylcholine receptors are bound with the antibodies, they would not respond to the acetylcholine signal, so there is no signal to the muscles and there is paralysis in the muscle. So this scenario is present in 85 to 90% of patients. Another 10% of patients, they do not have immunoglobulin against acetylcholine receptor, so the acetylcholine receptor is working just fine. The problem is with the MuSK protein. This is the MuSK protein here. And the function of the MuSK protein is to monitor the integrity of the acetylcholine receptor. So this protein here would keep checking the rest of the acetylcholine receptors present in the neuromuscular synapse. And if there is any abnormality or if there is any damage in any of the acetylcholine receptors, it will give the orders to internalize these damaged acetylcholine receptors and synthesize a new healthy acetylcholine receptor. So when this MuSK protein is deactivated with autoantibodies, now there would be no continuous checkup of the acetylcholine receptor integrity. So there would be an accumulation of damaged, abnormal acetylcholine receptors, and these will not be replaced, will not be internalized because no order was given by the MuSK protein. And also no new acetylcholine receptors would be synthesized, again because there is no orders were given by the MuSK protein. So we will get, at the end of the stage, we will get to the same result where there is no adequate acetylcholine receptor. In 85 to 90% of patients, the problem is directly with the acetylcholine receptor. The antibodies directly attack the acetylcholine receptor. In 5 to 15% of the patients, the problem is with the MuSK protein that is responsible for maintaining the integrity of the acetylcholine receptor. Myasthenia gravis occurs in prevalence of 5 to 10 cases every 100,000, and this prevalence is constant all over the world. There's no change among different species, different races, or different areas in the world. There's a sort of peculiar trend in developing myasthenia gravis or gravis. The females usually tend to develop the disease at earlier age, at their 20s, while men are, they start developing the disease at the age of 50. So this is sort of peculiar feature of myasthenia gravis. 60% of the patients of myasthenia gravis, they have thymic hyperplasia, and some of them, they have a tumor of the thymus known as thymoma. Doing thymectomy would increase or will improve the condition in 25% of the patients. And so there is a unique relationship between the thymus and myasthenia gravis. The exact relationship is not really known. However, it is the thymus is the site where the T helper cells or the T cells are being trained to recognize self-antigens. And there is one possibility that the presence of hyperplasia indicates or giving the possibility that there is a chance to have epitopes similar to the acetylcholine receptors, or at least to one of the units of the acetylcholine receptors that will make it a target for antibody attack. So the exact mechanism or the exact relationship between the thymus or the thymic hyperplasia and the myasthenia gravis is not well known. However, it does make sense because the thymus is the site where
the T cells are trained to recognize self. And there must be also in the thymic hyperplasia, they found that the thymus is occupied with massive amount of germinal centers with the B cells that would be excessively activated by the helper T cell to produce a huge amount of autoantibodies. Also, another feature, let's say, of myasthenia gravis is sometimes it can be part of paraneoplastic syndrome. And in that case, when a patient develops a myasthenia gravis, this indicates or might indicate that he is developing cancer somewhere in the body. The most common reported cancerous lesions associated with myasthenia gravis is thymoma and bronchogenic carcinoma. So the patient should always be followed up. Patient diagnosed with myasthenia gravis should always be followed up for developing tumors, particularly in the thymus. What happens or what we can see if we take a biopsy from the patient with the myasthenia gravis, there would be lots of lymphocytes and macrophages at the neuromuscular junctions, lots of antibodies, IgG and C3. Actually, complement system do play a big role in myasthenia gravis, and it is the complement system is the one responsible for the damage that occurs in the muscles. So let's see what goes on. This is the normal. This is how things normally should happen. So there's the calcium influx that would allow the release of acetylcholine, and these hairy projections here are the acetylcholine receptors. The acetylcholine receptor consists of different subunits. So here it shows the different subunits of the acetylcholine receptors. So it binds with the acetylcholine, would bind with the receptors. This would induce depolarization and muscle contraction. Let's compare this to what happened in a patient with a myasthenia gravis. So in a patient with the myasthenia gravis, there are antibodies that bind with the receptors, preventing the binding with the acetylcholine. Also, the presence of the antibodies would trigger the complement system, the C3 complement system, that would initiate the cascade of the complement system, forming the complex, the complement system complex that would form a hole within the myocyte and initiate damage of the muscle. Another mechanism is also having the antibodies binding with the acetylcholine receptors. This would recruit other inflammatory cells, including macrophages, that would also initiate an inflammatory reaction, myositis and inflammation in the muscle. The total effect of that is there would be no activity, no neuronal activity here in the muscle, and also there would be loss and damage of the muscle cell, and this would lead to progressive weakness of the muscle. Clinical features are mainly motor, and because the antibodies target the nicotinic receptors, the nicotinic acetylcholine receptors. The main and the most common is ptosis, where there's drooping of the eye, particularly toward the end of the day because of the fatigue, and when the case progress, it will start to become more of a constant feature. Diplopia, blurred vision, again because of the weakness of the oculomotor muscles. Bulbar symptoms, that includes weakness of the face and throat, so the patient would have difficulty speaking, difficulty swallowing, dysphagia, dysphonia. Also the voice is affected because the laryngeal muscles are affected. Weakness would spread to all over the body, and the worst scenario is the myasthenic crisis, where the respiratory muscles are affected and would become paralyzed, so the patient is not able to breathe, and the patient had to stay in a ventilator for a while until his condition is stabilized. How it is diagnosed, mainly by clinical features, measuring the autoantibodies. And treatment, there is a treatment for myasthenia gravis. Mainly, the aim of the treatment is to increase the amount of acetylcholine present at the neuromuscular junction. So the patient would take choline esterase inhibitor that would inhibit the choline esterase, which degrade the acetylcholine at the neuromuscular junction, because normally we need this enzyme to degrade the acetylcholine because there is no reuptake. So we need the acetylcholine and esterase to degrade the acetylcholine, so the muscle would go back into the resting potential and would be able to receive a new signal. For those patients, for myasthenia gravis patients, because we have low amount of receptors, we try to work by increasing the amount of acetylcholine to maintain the contractibility of the muscle, and we do this by inhibiting the enzyme that degrade acetylcholine. Steroids, immunosuppressants in general can be used to reduce the inflammatory reaction at the site of the neuromuscular junction. Azathioprine and cyclosporins are anti-T cells, so they work specifically on T cells. IV immunoglobulins and plasmapheresis are important in reducing the amount of autoantibodies. The surgical removal of the thymus is a major part of a treatment and induce improvement in high percentage, in 25% of the patients. The patient need to be followed up constantly for any tumors, and if the thymus was not removed, the patient needs to go under regular checkups for any enlargement or hyperplasia within the thymus. Okay, so this is what I wanted to share with you regarding the nervous system, different cells in the nervous system, inflammation, conduction within the central nervous system. And I just shared with you 2 examples of the most common neurological disorders mediated by autoimmune or immune or dysregulation. There are, of course, different conditions, but could not cover it in this topic. You can refer back to the textbook, our textbook, to to have an idea about the different conditions that might affect the nervous system. Thank you very much, and see you next week. Bye bye.